Good morning, everybody, and welcome on behalf of the UAB Memory Disorders Clinic. So the topic for the next 30 minutes or so is Alzheimer's disease, an update for 2012. And pretty much everything that I'm going to talk about is data that was published in 2012 or things that were FDA approved in 2012 or data that was, in some cases, not even published yet but presented at meetings in 2012. With just, I think, one exception that came right from the end of 2011. These are my disclosures. Really, the top line says it all. Nothing pertains to the topics discussed today. This is really what we're going to focus on. First topic is going to be what we've learned about the natural history of Alzheimer's disease, focusing on autosomal dominant early onset cases. Then we'll talk about diagnosis, new diagnostic criteria, and a new amyloid imaging agent that's now widely available. And then we'll talk about some new options in terms of treatment and new data in terms of treatment options. So the first thing I wanted to do was just to talk a little bit about the difference between late onset and early onset Alzheimer's disease. This is becoming a more and more important topic as we study this disease. Of course, late onset Alzheimer's disease is what we usually mean when we say Alzheimer's disease. Cases that begin at age 65 or older. And it's a very common disease, getting more common as we have more and more people aging into this demographic. About 6.5% of the elderly population, or if you put that per 100,000, 6,500 people per 100,000. Contrast that with early onset Alzheimer's disease, which is usually defined in the literature as onset of 60 or before. You'll see there's a little window between 61 and 64 where you can't get Alzheimer's disease, apparently. So you can look forward to that. It's obviously much more rare, only 40 per 100,000 overall. And of this early onset, there is a smaller piece, which is autosomal dominant early onset. And this is only 5 out of 100,000, so not all early onsets are autosomal dominant. These autosomal dominants are the earlier end of this early onset range, usually with clinical onset in the mid-40s. And the rest of these cases, the other 35 or so per 100,000, are often cases that may be presenting in the 50s, and it's thought that many of these might be autosomal recessive. We don't know the genetic basis of them at this point. Now, in the last few years, of course, we've learned about many of the genes that cause these autosomal dominant forms of the disease, and there are 3 of them that have been identified: amyloid precursor protein, and then presenilin 1 and 2. All of these genes are related to A-beta. APP is the precursor protein for A-beta, and presenilin is the enzymatically active component of gamma secretase, the enzyme that produces A-beta. And just to review the pathophysiology here of A-beta production, APP is cleaved first by beta secretase and then by gamma secretase, which does this intramembranous cleavage to release the A-beta peptide into the extracellular space. So all of these genes are tightly linked to A-beta production, and the mutations in these genes lead to overproduction of A-beta, either by favoring the cleavage on the substrate side or by making the enzyme a better cutter to produce more A-beta. There are 2 large studies now ongoing of these early onset autosomal dominant cases. What has motivated these studies is the fact that this population is unique in that we can identify on the basis of who is carrying the mutation people who are going to develop the disease many, many years before they ever have any symptom, right? So essentially, from the time an infant is born, you can genotype them, members of these families, and you can identify who is going to develop Alzheimer's disease at age 45. And essentially, you can track them now and be able to study this pre-symptomatic stage of the disease that would be very hard to do in the typical late onset type of case, where we don't know who it is that's going to be developing the disease. So one of these studies is called DIANE. It's based at Washington University, and it's enrolling people all over the country, and actually there are some sites in Europe as well. So patients with any mutations in any of these 3 genes. The second study is called the Alzheimer's Prevention Initiative. It's based in Arizona, and this group is studying a very large kindred in Colombia, South America, that carries one specific mutation in presenilin 1. This is a very large and well-studied group with hundreds of members in the extended family to study. So these studies have been enrolling mutation carriers pre-symptomatically and then following them for years with imaging and CSF and blood tests to identify the time course of changes that occur through the lifetime leading up to the onset of disease. And this is going to kind of summarize what we've learned from these studies. I'm going to put this on a timeline where time 0 is when the first symptoms begin. So this is really when we would be diagnosing somebody with mild cognitive impairment. We know we can follow people back at least 20 years before this. Remember, the age, the actual age here is around age 45 on average. So we're talking about people in the early 20s. Most of these studies don't really begin until patients are at least age 18 when they consent to this. So we don't have great information yet on before this, but we know that at least 20 years before, levels of CSF A-beta are increased above normal, which kind of makes sense because all of these mutations increase A-beta production, and that there is abnormal increased activation on FDG PET. So there are areas of the brain that are utilizing more glucose than normal. 15 years before the onset of symptoms, plaque deposition begins. The hippocampus begins to atrophy. CSF tau increases, and A-beta levels are declining throughout. Actually, they're on their way down, even from this they're above normal, but on their way down. And so about 15 years, they're crossing normal. We call it pseudo-normal, on their way down. 10 years before, CSF A-beta levels are below normal. FDG PET shows hypometabolism, and on episodic memory testing, neurocognitive testing, there are episodic memory deficits. So this is before any memory symptoms are developing in day-to-day life. This is just something that's detected on formal cognitive testing. 5 years before the onset of symptoms, cognitive testing reveals deficits in multiple domains in addition to memory. And then, of course, now at time 0, we get the memory symptom. On average, about 3 years after that, function becomes impaired. In other words, consistent with the diagnosis of dementia. And then median survival is around 12 to 14 years. So these very interesting, elegant studies have been able to lay out this whole time course that we would never have been able to identify in late onset disease. And just to kind of show you in video form, this is data from the API study. And it's going to show you amyloid imaging over time. This is going to start, this x-axis is now in terms of actual age. So it's going to start at age 20. And the onset of disease in this case is around age 45. So you can just kind of watch the amyloid deposition occur following along on that graph at the bottom here. And you see that the ticker is counting down the number of years before symptom onset. These patients, this is still green. This patient is still healthy and asymptomatic. You can see this tremendous amount of amyloid deposition going on now. We're still 7 years before symptom onset at this point, 5 years before the onset. Now right here we hit symptom onset. You see this changes to clinically affected. And now watch the change in amyloid deposition after this point, really very little change. Just to kind of visually emphasize the fact that almost all the amyloid deposition occurs before the onset of symptoms. By the time that you present with MCI, the first time you've lost your keys, really you have already a full load of amyloid plaque in the brain. Now, just to come back to this, all of the data that I just showed you is derived from early onset Alzheimer's disease. We don't know for sure whether all of this applies to late onset disease. To the extent that data is available, it seems that most of these lessons apply, with the one possibility that that very first abnormality of increased CSF A-beta and increased activation on FDG PET may be unique to the early onset cases because of the fact that they have CSF, because that they have A-beta overproduction as part of their pathophysiology. Okay, so that's what I want to say about natural history. Let's change gears to diagnosis. There are new diagnostic criteria published by the NIA and the Alzheimer's Association in this past year. And we're going to kind of walk through these fairly quickly. The first criteria, of course, is for dementia, not specifying a cause, but just for dementia. And it's not dramatically different from our prior criteria for dementia, basically the presence of cognitive or behavioral symptoms that interfere with work or activities of daily living and causing a decline from a prior level of function, so the requirement for some functional impairment. It's not delirium, it's not a psychiatric illness, It's present by both subjective and objective means, and it involves at least 2 cognitive domains. That's the definition, the criteria for dementia. These are the criteria for probable Alzheimer's disease dementia. So in order to implicate Alzheimer's disease as the cause of the dementia, there must be insidious onset, clear-cut history of worsening. You can categorize it as either an amnestic case presentation where the memory deficits are the initial and most prominent deficits, or non-amnestic or a more atypical presentation with language, visuospatial, or executive presentation. And then no substantial vascular disease or other neurodegenerative disease that is thought to be the cause of that. There's also a new category called probable AD with an increased level of certainty when there's actual documented decline. So you've actually seen someone on follow-up and documented some decline, and it's not just decline by history, or the presence of one of the 3 pathogenic mutations that I talked about earlier. But probably the most interesting and important change in this diagnostic criteria is the addition of probable AD dementia with evidence of AD pathophysiology. And this gets into biomarkers. So actually, all the clinical criteria that we have used to date are purely clinical and really do not invoke anything that points to what we know about the biology of Alzheimer's disease as a cause. Now, these biomarkers are broken down into 2 categories in the criteria. Biomarkers of A-beta deposition in the brain, which can be either reduced CSF A-beta or amyloid imaging positivity. And then biomarkers of downstream neuronal degeneration or neuronal injury, which include an increase in CSF tau, either total or phosphorylated. Phosphorylated is generally thought to be more specific for Alzheimer's disease, but either can work, will satisfy these criteria. A decrease in FTG PET in the posterior regions that we associate with Alzheimer's disease, posterior temporal parietal cortex. And then disproportionate hippocampal atrophy or medial parietal atrophy. And why do we focus on this in terms of these regions in terms of the atrophy? Because this is really where the tau pathology is. So this is whole brain sections that are stained with antibodies against phosphorylated tau to show you where the tau pathology begins. And this is stage 1, Brock stage 1, 2, 3, 4, 5, and 6. And you can see that this entorhinal, pararenal, and hippocampal regions is where the tau pathology starts. And so this is where the injury is most intense. And that's why we're looking for disproportionate atrophy in these brain regions. Now, a lot of the studies that were done to obtain the data that disproportionate hippocampal atrophy is a feature of Alzheimer's disease were obtained by formal, quantitative, statistical methods that aren't really available to us when we're seeing a patient in the clinic. But there are now visual rating scales that enable you to look at an MRI in a coronal section of an MRI and make an impression on a 1 through 4 scale of how much hippocampal atrophy there is. So this is the hippocampus, the entorhinal cortex, and the perirenal cortex, the 3 key regions. And generally speaking, the hippocampus is is the place to focus on this. You see a normal hippocampus here, an atrophied hippocampus here. And the way that we rate this in the clinic, and UAB neuroradiologists are now reading this out on many of their reads when we send them a patient and indicate that it's for the workup of Alzheimer's disease. 0 out of 4 atrophy would be a normal hippocampus where you really don't see much of the inferior horn of the lateral ventricle. 1 out of 4 is where you do see clear ventricle. My rule of thumb for 2 out of 4 is when the ventricle is about the same size as the hippocampus, and then 3 out of 4 is when the ventricle is bigger than the hippocampus. 4 out of 4 hippocampal atrophy is when the hippocampus is really just a little nubbin on the wall of the inferior horn of the ventricle. So 0 to 1 is what's usually seen in normal cases. A 2 or more is suggestive of Alzheimer's disease. So how do we implement these criteria in terms of, or these biomarkers in terms of the criteria? So in a patient who you have diagnosed clinically with probable Alzheimer's disease, you have the A-beta biomarkers, which is either amyloid imaging, amyloid PET scans, or CSF A-beta. And then you have the neuronal injury biomarkers, which are CSF tau, FTG PET, and structural MRI with the hippocampal atrophy. Now, if these aren't available, then the biomarker is uninformative, then you just have probable AD clinically diagnosed. If they are negative, then it is unlikely to be Alzheimer's disease. We would generally would not be expected to have Alzheimer's disease pathophysiology with normal A beta biomarkers and no evidence of neuronal injury. If one or the other, but not both, are positive, so they'll be in this category, then the diagnosis would be probable AD with an intermediate probability of AD pathophysiology. And if they're both positive, then we'd say probable AD with a high level of AD probability of AD pathophysiology. What's also new, and I think even more important, is the implementation of this in the diagnosis of mild cognitive impairment. Previously, Alzheimer's disease required dementia. We only had Alzheimer's disease was a form of dementia, and we did not apply that term to mild cognitive impairment. But of course, that doesn't really make sense biologically. The same biological process is impairing cognition in mild cognitive impairment as it is in Alzheimer's disease. And so now in patients who are clinically diagnosed with MCI, we can use a similar set of biomarkers. If both are negative, then the MCI is unlikely to be due to Alzheimer's disease. But now we have ways to make a diagnosis that the term being used is MCI due to AD, due to Alzheimer's disease, with intermediate likelihood if one but not both are positive, and a high likelihood if both of these types of biomarkers are positive. And of course, you would only need one from each category. So if you had CSF biomarkers and you could have low A beta and high tau, that would put you in this category. You wouldn't need amyloid imaging. You don't need multiple biomarkers on either side of that. Let's talk just a little bit more about amyloid imaging. This is amyloid imaging using Pittsburgh compound B, or PIB. This is something that's been around since 2004. And you probably have all seen these scans. It's now been widely used in research studies. It is not widely used clinically because the isotope is carbon-11 labeled, has a very short half-life, and basically you have to have a cyclotron on site at your PET scanner to be able to make enough of this and use it right away. So unless you have a cyclotron, you can't do PIB PET scanning. There has been a lot of interest over the last couple years of making F18 labeled PET ligands for doing amyloid imaging that would be, because of the longer half-life of F18, that would be able to be shipped by FedEx and could then be used anywhere there's a PET scanner. And the first of these to come to market is called Amyvid. Florbetapir is the generic name. It was approved in April of this year. And it's an F18 labeled amyloid imaging agent for PET scanning. It's not cheap. Wholesale's at $1,600, and I think the price, when it actually, to the patient, including the imaging time and whatnot, is $3,000, $3,500 in that range. And at this point, it's not covered by Medicare, so it's not, I don't think, being very widely used because of the cost. A note about the indication for this. Although there will be some patients who are interested in having this done to see if they have Alzheimer's disease, I'm talking about cognitively normal people who want this done as a screening test. That is not an approved indication for this agent. The indication for this is adults with cognitive impairment who are being worked up for Alzheimer's disease, and you want to ask the question, you want to see if you can provide some biomarker evidence for AD pathophysiology to go with your clinical diagnosis of probable AD or possible AD, not for screening cognitively unimpaired people. And the interpretation is also worth emphasizing. A negative scan is inconsistent with Alzheimer's disease. So in a patient with cognitive impairment and a negative scan, it would make you think, Lewy body disease, vascular dementia, some other kind of pathophysiology. A positive scan is not necessarily diagnostic of Alzheimer's disease. It certainly would provide one of the biomarkers that I mentioned in the table before, but if you don't have the other biomarker, a neuronal injury biomarker, you'd still only be at intermediate level of probability. And part of this is the fact that because of the fact that amyloid deposition occurs so early before the development of symptoms, around 30% of cognitively normal older people who undergo these kind of studies will have a positive scan. And we still are doing those kind of longitudinal studies to be able to determine if every one of them is necessarily going to develop Alzheimer's disease at some point in the future. So this is an amyloid PET scan. Do you think this is a positive scan or a negative scan? Looks kind of like a positive scan. I put this up here just to point out one thing about the amyloid as compared to the PIB PET scans that we're used to seeing is that the amyloid scans, these F18 scans, bind to the white matter a lot more. So even in a negative scan, there's a lot of white matter binding, and what you really are looking for is the cortical binding. That's what makes a positive amyloid scan. I just wanted to make this point, and you can see it a little bit more clearly here. In case any of you are ordering the scans and see the data yourself, there is a whole training paradigm that you have to go through to be able to read these scans. And you're really focusing, if you see this void in the cortical region, that's a negative scan, despite the fact that there's what looks at first glance to be quite a bit of a signal in these scans. You're really looking for that density going all the way out through the cortex. And just a reminder that although there's been a lot of attention paid to the new F18 biomarkers for amyloid imaging, and we still have the CSF tests, and I think there are some advantages to the CSF tests. One is that with 1 LP you can get a simultaneous measure of both sides of the equation. You can get both A beta and tau, and so you can measure both types of biomarkers. It's probably more cost effective than almost certainly more cost effective, and we'll get more and more as more and more people are doing these, and the cost of the lab work for doing the A beta and tau comes down. And these are really very well tolerated. The rate of post-LP headaches in the older people that are getting these TAPs is much lower than the rate in younger people. All right, so that's what I want to say about diagnosis. Let's wrap up with some thoughts on treatment. So a couple of the new things available in the last year are higher doses of Aricept and Exelon. So Aricept 23 milligrams is now approved for moderate to severe Alzheimer's disease. You're supposed to be on 10 milligrams, the old standard, for at least 3 months before titrating up to this. And the data showed basically improvements in the cognitive biomarkers, but not the functional or the cognitive outcome measures, but not the functional outcome measures. And this is the data from the trial that was published this year. This is these are patients with moderate to severe Alzheimer's disease, many mentals less than 20. These are the patients who progressed on 10 milligrams and showed some decline, and the patients who on 23 more or less stayed about the same, and there was a significant separation between these two groups. The cost of that, of course, was side effects, and they're kind of what you'd expect with these cholinesterase inhibitors. Nausea, vomiting, diarrhea, all occurring at significantly higher rates on the 23 than with the 10 milligram group. So it can be an option in patients who are showing some decline on 10 milligrams, but you do need to be aware of the side effects. And now similarly, just approved in this fall is the higher dose of the Exelon patch. Previously available in 4.6 and 9.5 milligrams, now at 13.3. This is actually approved for mild to moderate. The Aricept 23 is approved for moderate to severe. The Optima study was a study that looked at this, comparing the 9.5 to the 13.3 in a 1-year study. And here the functional outcome measures were significant. The cognitive ones were significant at 24 weeks, but not at the end point of the trial. And again, the GI side effects are more common on the higher dose, which is somewhat unfortunate, because that's one of the main reasons that we tend to go to the Exelon patch, is to avoid the GI side effects that you get with the oral administration of Aricept. But it does provide higher dose, of course. With the Exelon, you're going to be, in the brand name anyway. With the Aricept, you have the option of the generic donepezil at this point, which is another fairly recent development in Alzheimer's disease. Here it's a titration up after 4 weeks on the 9.5. Second related topic under treatment is there's also a study that was published in the New England Journal this year called the Domino trial. This was a trial that was designed to get at the question, what do I do when I have a patient with moderate to severe Alzheimer's disease who's on donepezil but is getting worse? Do I give up and say, well, they're past the point where this is helpful, I just stop it? Do I switch them to memantine? Do I just add memantine? And that's really, so we had that's the things that were tried here. So they took patients with moderate to severe AD, defined as a mini between 5 and 13, who were getting worse. And they either, this is the status quo, continue donepezil and just give some placebo memantine. This is stop everything, stop the donepezil and don't start memantine. This is continue the donepezil and start memantine, so this is adding memantine to donepezil. And then this is the switch, stopping the donepezil but changing them to memantine. So they basically randomized people to these 4 groups. And this is a summary of what they found. Basically, this is the severe mini-mental, so it's, I'm sorry, the standardized mini-mental. So this is, everybody's getting worse with time on this. But the group that's getting worse the fastest is the group that's taken off of both medications. The group that did the best is the one that is on both the donepezil and memantine. And then the one or the other are sort of in between. But the magnitude of the effect for donepezil, so if you compare adding, this is without memantine, here's no donepezil and with donepezil, and then with memantine, here's no donepezil with donepezil. Donepezil had the bigger effect, reducing the cognitive decline by 32%, which was significant. Memantine had a beneficial effect in terms of the rate of decline, but it did not reach significance. So even though it sometimes seems like these agents don't have a lot of effect and that our patients are declining even when they're on them, there is now evidence that stopping them, they'll do even worse. All right, let's talk about the monoclonal antibodies finally here, because this is a topic that's really been very hot in the news this fall. There are at least 4 antibodies that are out there that have been getting talked about a lot or will be getting talked a lot about soon. Bapineuzumab is the antibody originally from Exelon and Wyeth and then licensed out to Janssen and Pfizer. And solanezumab is the one from Eli Lilly. These 2 both reported results this fall, and we'll get to those in just a second. Then there's the one from Roche called gantenerumab and one from Genentech called crenezumab. And you see there are differences in terms of what part of this we recognize as a different part of A-beta. This recognizes a conformational epitope that's not based on primary sequence. And also in terms of the IgG, the crenezumab, the unique feature is that it's made with IgG4 backbone, which activates microglia less, so it's designed to have a less of an inflammatory reaction and therefore be safer. As we'll see, as I'm going to tell you in a second, adverse effects have been a limiting problem with these antibodies. And they bind to different types of A-beta and generally have different strategies. Solanezumab binds to monomeric A-beta and is thought to basically be a peripheral sink that sucks A-beta out of the central nervous system by binding to it in the plasma, whereas other of these antibodies are believed to actually get into the brain and bind to A-beta and to facilitate its clearance. So we're talking about the data here for bapineuzumab first and then solanezumab. These are the data, they're still unpublished. This is the data that was presented in September at the European meeting in Stockholm. This trial compared 0.5, 1.1, and 2 milligrams per kilogram IV given quarterly, essentially, for a year and a half. And you can see the results pretty clearly here. There was no effect. When you look at the amyloid imaging, though, to say, how much of the amyloid did they actually clear out of the brain, the answer is at the end of the trial, there was no difference in the amyloid plaque load in these patients. So this was somewhat surprising. The whole point of these therapies has been to get rid of A-beta, and it's something that they have been shown to do previously. And I think the main reason for that, in the case of bapineuzumab, is toxicity. So we talk about area, which is amyloid-related imaging abnormalities. So they can basically either be, area E is edema, area H is microhemorrhage. And these are the things that the main side effect we worry about when we treat patients with these A-beta antibodies. So they get, all these patients got an MRI 2 weeks after each dose to look and see if they had any of these abnormalities. They're mostly asymptomatic, but there are still some that are symptomatic. So you can see even on the lowest dose, 4% had these abnormalities, 1.5% were symptomatic, and on the 1 milligram dose, almost 10% had at least asymptomatic area. The 2 milligram dose was actually stopped early because it was stopped by the Data Safety Monitoring Board because of the toxicity. So basically with bapineuzumab, the drug is just too toxic to give enough of it to really do anything, is the answer. Solanezumab, the Lilly compound that binds in the middle of A-beta, showed somewhat more promising results. They did 2 trials simultaneously so that they could have be able to go to the FDA right away. They call them Expedition 1 and Expedition 2. This is the data for the mild cases. So they did both mild and moderate. In Expedition 1, this is a subgroup analysis, and then based on this, in Expedition 2, they pre-specified that they were just going to look at mild. But basically, they see a significant result in a benefit of the drug in mild cases here. Looks like a similar pattern, but it didn't reach significance in the other trial. But when you pull the 2 trials together, it was significant in the mild cases. In the moderate cases, you can see here pretty clearly from the pooled data, there was no effect. So provides a little glimmer of hope that these antibodies might actually be doing something. Some very tentative evidence for the amyloid hypothesis, I guess, which we're still looking for, some evidence that actually targeting A-beta is beneficial in the disease. But this is a very small effect even in the mild cases, and this is not the primary outcome measure of the trial that they hit on here. So there are definitely some issues then with the strength of the data. The safety profile, though, is quite a bit better with the solanezumab, just to make the point that not all A-beta immunotherapy is the same. This is an example of area E, and in solanezumab was only 1%, and only 1 patient in the whole trial was symptomatic, and this really was only marginally different from what was seen in the placebo group. So at this point, bapineuzumab is dead. That program has been terminated this fall with the results that were published. Solanezumab is now progressing into the DIANE trial. So that's the early onset familial autosomal dominant study that I was talking to you about earlier. Basically going into patients where we know we can treat them pre-symptomatically when they haven't had amyloid in their brain for 15 or 20 years already. And then the other 2, the ones from Roche and Genentech, both have trials ongoing in late onset AD. This one is called Scarlet Road. It's in what they call prodromal AD, which is really, it's basically MCI with low CSF A-beta. So it's basically, MCI with at least intermediate evidence for AD pathophysiology, according to the criteria that I showed you earlier. And then they are also going to be participating in the DIANE trial to look at pre-symptomatic treatment. And then crenezumab is doing a trial called ABBY in mild to moderate AD, and then it's going to be the drug used in the API trial, the other big autosomal dominant trial that I showed you. So we're looking forward to Scarlet Road and ABBY should be reporting sometime fairly soon. The DIANE and API are just getting started. And then this is just to conclude. Basically, this is just kind of what I mentioned, that they're now getting into both in DIANE and API, which are looking at autosomal dominant, or these early onset cases, are getting into treatment trials where we'll be treating patients well before any symptoms to see if in this period when the amyloid hasn't been so entrenched for so long, if targeting A-beta might be more helpful. DIANE is testing both solanezumab and gantenerumab and also a BACE inhibitor. So they're basically doing a 3 treatment arm with 1 combined placebo as a way to kind of enrich the number of patients in the trial who actually get an active drug. API is looking at crenezumab. And then there's a 3rd trial that's worth noting. This is in late onset now. And it's also a trial looking at asymptomatic AD. This is called the A4 trial. And their strategy, rather than trying to find mutation carriers, is to basically do a lot of amyloid imaging in cognitively normal older people, and then to take those patients from those screening studies who are amyloid positive, and that's where they're going to treat for these trials. They have not yet announced what drug they're going to be doing in their treatment trials, but that should be coming up probably shortly after the new year, I believe. Okay, so final thoughts. Things that I really want you to take home from this. Alzheimer's disease has a long pre-symptomatic phase, and most of the A-beta deposition, almost all of the A-beta deposition, is complete before any symptoms that even actually begin. We have new diagnostic criteria, an increasing role for biomarkers. Now, biomarkers are not required for the for average clinical use. They're available, and I'm trying to kind of lay out how you might incorporate them, but it is not necessary to do biomarkers to make a diagnosis of AD, but they can help increase the likelihood of AD pathophysiology. Treatment-wise, cholinesterase inhibitors are still the mainstay. We have options now for higher doses, and we also have the generic donepezil now for Aricept. And then antibody trials with some mixed results at best so far, and they're moving now to early onset Alzheimer's disease. So I will stop there.
Thank you. Thank you, David. It's a pleasure to be here. It's always disconcerting to give a talk following a lecture that points out the preliminary signs of dementia. I paid pretty close attention to those slides, and I wish you hadn't mentioned the lost keys as the gateway problem, because that happens to me quite a bit. That was a very elegant talk. What I'd like to do is talk about the role of neurosurgery in Alzheimer's. None of what you're going to see here today is available for standard treatment. This is all investigative, but provocative. No disclosures for this project. So you heard more than you want to know really about Alzheimer's disease. I won't dwell on that. But for the purposes of this talk, imagine it as a deficiency in the cholinergic system and network. And that's what these investigative trials are aimed towards, except for the first two. I'll talk very briefly about shunting for Alzheimer's, cortical revascularization, neuromodulation, and restorative therapies. Sometimes we get patients who are either have NPH or Alzheimer's. We can't quite figure it out. Thinking can go, well, we can't cure Alzheimer's. Why not do a shunt? Well, this is a good reason not to do a shunt, because Jerry Silverberg at Stanford performed a randomized trial of shunting with an open shunt or with a closed shunt. There's no difference. So shunting has no role in Alzheimer's. The following study was a surgical forte where this group pulled omentum up to revascularize the cortex. A tremendous surgical success, and they reported a 34-fold increase in performance. But for reasons not clear, nobody's picked that up, and I wouldn't advise that as a thought. Neuromodulation is more interesting. In my practice, we do a lot of neuromodulation for Parkinson's disease, and the idea there is that we're modulating the deficient neuronal network, which is the dopaminergic system. So there's some reason to think that if you can modulate the deficient cholinergic system in Alzheimer's, you may see some amelioration of symptoms, and we certainly see that in Parkinson's disease. So there is reason to think you might see it in Alzheimer's. The group out of Toronto did preliminary studies on 6 patients where they stimulated here the fornices, and they found some encouraging results, both in terms of imaging and behavior. And this has prompted, as you can see here, a clinical trial which is underway. It's a 40-patient trial, double-blind, randomized, a very well-structured trial to look at forniceal stimulation with deep brain stimulators for Alzheimer's disease. That's probably the best trial underway right now. There are a number of US and Canadian centers involved. There are 5 other active clinical trials using deep brain stimulator in various areas within the cholinergic system. No results reported. Restorative treatment from a surgical standpoint and from a mechanism standpoint probably holds the most promise outside of pure cell biology, if you will. And restorative treatment can be viewed as either replacing degenerated neurons, cell implants, stem cells, or precursor cells, or slowing the degeneration or regeneration of abnormal neurons. And both of those tacks have been taken. Here are 2 or 3 studies that seem to indicate that stem cell implants or cholinergic-rich precursor cell implants into various areas of the brain not only indicate that these cells can survive, but they can improve performance in rat models of Alzheimer's disease. I won't say a lot more about that, except that it does hold promise, and there are a number of studies and trials underway both in the lab and clinically to look at stem cell treatment for Alzheimer's disease. Stem cell treatment has its own peculiar problems. It's hard to manage these cells, and patients can get in trouble with them, but the idea certainly seems worth pursuing. This strategy, I think, holds more promise. The neurotrophic strategies, either with instilling nerve growth factor or directly, which has been done. There's sufficient evidence to suggest that nerve growth factor can not only halt degeneration of cholinergic cells, but result in some regeneration and also increase the cholinergic output and improve behavior in animals. Transgenic methodology, which is the trial I'll talk about in a bit, is the insertion of nerve growth factor DNA into a viral vector. And there have been trials both in humans and animals to suggest that this is a safe route to either prevent degeneration or regenerate neurons in the cholinergic system. We'll talk about that a little more. So I think gene therapy certainly holds promise in this regard. So the rationale for nerve growth factor trials is to promote cell survival, to stimulate cholinergic signaling, and improve symptomatology. If you did all of this and the patients didn't get better, it may be an interesting academic exercise, but not clinically beneficial. The natural target is the basal forebrain of the basal nucleus of Meinert, which is sort of the cholinergic driver. And you can see in these preliminary studies that nerve growth factor in a gene delivery model can prevent neuronal loss in the aged monkey and also regenerate neurons in a lesioned monkey. So there's promise there. Serogene is a company that was formed in San Diego, out of work done at the University of San Diego. The translational product here was the insertion of nerve growth factor DNA into an adeno-associated virus, and that vector can be used to instill this nerve growth factor into various tissues here of the brain. And so this company has conducted several clinical trials investigating the properties of nerve growth factor in ameliorating symptoms of Parkinson's and Alzheimer's. We'll talk about Alzheimer's today. It has a significant benefit in that it's not an insertional gene. The virus particles replicate in the neuron. They don't cause mutagenesis, so it's fairly safe. And it's well studied as a vector in many animals and, to this day, humans. So in order for this to work, the injection site, which we'll talk about in a minute, has to be restricted to the target region. If this compound or if this gene disseminates into the spinal fluid, it causes a very unfortunate pain syndrome. It can't cross the blood-brain barrier or get out into the systemic tissue. And you have to have a continuous supply of the protein in the targeted area. It must improve performance, and it's got to be safe. So these investigators in San Diego, in conjunction with Serogene Incorporated, performed a well-designed study to investigate these properties of SER-110, which is what they call their AAV2 virus that holds the growth factor DNA. They found that there was an orderly dose relationship. It was restricted to the stereotactic target, and it was persistently expressed after 2 years. They did find suggestion of clinical efficacy in rats. It's interesting to think about a rat having Alzheimer's, but they seem to find clinical efficacy. And it was safe, and they felt it was suitable for human trials. These are just some of their rat trials, and they found that there was a dose-related persistence of the protein in the rat brain. They found that it persisted in rats and subhuman primates over a number of years, so that satisfies that, and it resulted in regeneration and halt of degeneration. All of those excellent precursors for a human trial. And these are the same results in subhuman primates, that the persistence of the nerve growth factor was dose-related, and it persisted for a number of years. And it tended to stay right where they put it. So based on that, they mounted a pilot study looking at about 10 patients where this viral vector was injected into the region of the nucleus basalis. This was a safety study. It was done at Rush and also, I think, in San Diego. What they found in this study was encouraging. After injection of the viral vector in the nucleus basalis, which is located right there, they found that it was fairly safe. There were 6 adverse events not related to the injection. One patient had a subdural related to the surgery. They found in autopsy studies that the injection was located where they put it. It didn't seem to migrate throughout the brain. In systemic assays, they didn't find significant virus in the other organ systems. And they found a suggestion of a clinical response in these 10 patients, which is good justification for mounting a phase 2 trial, which is what they've done. And it's the trial that we're involved in at UAB. So this trial is a double-blinded, placebo-controlled sham surgery trial to investigate the efficacy of this viral vector with nerve growth factor in impacting Alzheimer's disease. It's coordinated by the Alzheimer's Disease Cooperative Study, and the IDN sponsor is Serogene. To give some idea of the interest in this, particularly in the fact there's no definitive results, is that Serogene has just completed their D round of investment for about $20 million. So despite the fact that there's no clinical results, the impact of Alzheimer's is significant justification to move this research along, and I think it's good research. The UAB study personnel, Dr. Watts is the neurology PI, and I can't say enough about the group of people involved in this. These are extraordinary folks to work with. Stephanie is our surgical coordinator. No relation to me. I tell people I'm her son. These are the participating institutions. So there are 10 institutions involved in this trial, which started about 3 years ago. It's a phase 2 trial. It's double-blinded. I'll talk about that in a minute. There are 10 institutions. Approximately 50 subjects was the target. 25 are going to be injected, and 25 are going to have a sham surgery, and I'll talk about that. They estimated the study enrollment period to be 12 months. It's now 3 years, and the study is just about to close. So it always takes longer than estimated. Here are the primary objectives is an effect of Sierra 110 on cognition, as assayed a number of ways, and secondary, of course, is to look at a broader effect of this in order to design a broader trial. Won't go through it, but there are a fair number of inclusion and exclusion criteria. And the endpoints, the primary endpoint is an absolute change in baseline in cognition, and you can see a number of secondary endpoints here as a longer follow-up. And there are safety endpoints that you can read here. This is a very well-designed trial, and this corporation has put a lot of thought and effort behind this. Here's the study flow. There's about a 1 to 2 month evaluation period. The patient is brought into the operating room, and the decision as to whether to do sham surgery is made at that time, at the time the patient enters the operating room. So a patient is randomized either to surgery or sham, and then follow-up begins. So here you can see the metrics primarily related to cognitive impact of this surgery and the viral vector and the placebo. Looks like this. We put a head frame on. This is this patient did well. She doesn't look happy, but nobody would in that circumstance. This is the area of the forebrain in which we inject the viral vector. It's in the region of the nucleus basalis, and you can see the planning scan here. This is the injection mechanism, and so we manually inject a prescribed viral dose into this area, and this is what the setup looks like in surgery. So we sedate the patient to amnesia, so they can't know whether it was a sham surgery or a real surgery. At the time of surgery, we break open the vial. If it's empty, we do a sham surgery. If it contains virus, we do the real surgery. So no one really knows until the time of surgery. It takes about 4 hours to do the surgery. If it's a sham surgery, we time it, and we take the patient out of the OR in 4 hours. We do the incision, we drill through the outer table of the skull, we wait 4 hours, and we close, and that's the sham surgery. The patient spends the night in the ICU, and they're discharged the next day. The anesthesia staff, myself, and Stephanie Guthrie are unblinded. We follow the patient for a day or two and are involved if there are any acute surgical problems. After that, a blinded staff, including the neurology staff and nursing, and Denise Ledlow, who is the nurse coordinator, take care of the patient, rate the patient. They've got no idea whether the patient had the real or sham surgery. We can break the blind for emergencies, and that's only happened once in the 3 of these gene therapy trials we've been involved in. Here's a post-op scan, and you can see the trajectories that we use to inject the virus into the basal forebrain. Here's accrual to date. We're right at 49 with a target of 50, so the trial is about to close. And so we've done pretty well up here accruing. So we don't have any results from this trial, but what I can tell you is the notion of gene therapy to restore cholinergic activity in view of what you just heard about Parkinson's disease seems a blunt tool, but if this works out, it could be a tremendous asset to patients who have Alzheimer's. I believe these trials are well designed to demonstrate this, and the trial we're involved in is certainly one of those. We haven't had any significant adverse effects. I don't know of any in the trial. Any other information can't be talked about right now. We're not privy to that. Once the trial is accrued and the blind is broken after a year of follow-up, we'll know a lot more, but we're very enthusiastic about this trial. I think the role of neuromodulation is not yet well established, but we have reason to think it could be beneficial in these patients, much like Parkinson's, and we'll know hopefully in the next year or two. In terms of neurosurgery, you don't think of neurosurgery much in Alzheimer's disease, but I think things like viral vectors and neuromodulation will expand the role we have in Alzheimer's disease and also other degenerative disorders and functional disorders of the brain. It's going to be a significant growth area in neurosurgery. Any questions? Thank you.